can never have too many tools. Shop DeWalt deals at Lowe's. Get a free Select DeWalt 20-volt max power tool when you buy a Select 20-volt max 5-amp-hour battery kit. Plus, get a free additional DeWalt 20-volt max 8-amp-hour battery when you buy a DeWalt 10-inch 20-volt max dual-bevel compounded miter saw. Our best lineup is here at Lowe's. Valid through 6/24 while supplies last. Selection varies by location.
Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today, 3 more rules that will hopefully help you take care of your patients. Rule number 218, get objective data. So one of our problems as pediatric emergency physicians or just pediatric providers is that sometimes, many times, the data we get is not objective. The mom, the dad, the caregiver is saying what they're saying. The patient is a newborn or somebody who's not particularly cooperative, and it's very hard to get objective data. Of course, what the parents is saying, you take at face value. That's all you can do. You have to rely on that. But when possible, it's very important to get some objective data to the best you can. Now, let me explain, always good to explain with an example. So, leg weakness or weakness is something I've seen as a chief complaint in the pediatric emergency department many times. Sometimes to the point that the patient, usually an older child or a teenager, comes to the ER and he or she literally cannot stand. Their muscle weakness is so bad, they have difficulty standing, or at least that's what they say, and making them stand doesn't really help. In that situation, what I've learned from the neurologist, one of the best objective measures you can get is reflexes. So a patient who's complaining of weakness, who has normal reflexes, is a very reassuring sign. Essentially, the reflexes indicate that the muscle is working, the nerve pathways are working, and that helps you get objective data beyond the fact that the patient is refusing or says he or she cannot stand. Having reflexes tests the true strength and neurological status of the extremity. And that is objective data that goes a long way, more than just I am unable to stand or my legs feel weak. Another good example that I think most of us know, and it's kind of a basic physical exam skill we all learned in medical school, is looking at the child while palpating the abdomen. So we all know abdominal pain, unfortunately, is a very, very common chief complaint in the pediatric emergency department. We all see it every shift. Kid comes in, it hurts here, it hurts there, it hurts for a day, it hurts for a month. And I think all of us learned a very easy trick of looking at the child's face when palpating the abdomen. So I very much respect any child that says he or she have pain. However, if I'm palpating the abdomen, deeply looking at your face and you have no grimacing, no screaming, no complaining, I'm not particularly concerned about an organic cause or serious cause of abdominal pain. So looking at the child while palpating the abdomen or the extremity, if the chief complaint is extremity pain, etc., gives you objective data. Always very important to get objective data. Another good example, and perhaps most important objective measures and objective data we get, is the vital signs, which I think, myself included, is often dismissed. I think they're called vital signs for a reason, because they're vital, and looking at them helps you get a lot of information about the child's status. For example, we all know tachycardia is a very sensitive sign for dehydration, acute abdomen, sepsis, etc. So looking at the vital signs before you even do the exam or before you even see the child often gives you some objective measures. Rule number 219. Think about what most doctors would do in your place. So this rule can basically be replaced by a term I think we all know and very familiar with, standard of care. I think it's very helpful when working, especially if you work in a single coverage unit, which I used to do in Florida. very helpful to think about what would most doctors do in your circumstances. And that goes a very long way, especially if you have some kind of a relationship with the patient that maybe is a bit negative. So some patients or some parents come across as rude or dismissive and not particularly nice and easy to work with. And oftentimes that clouds your judgment in terms of your care or the care you provide for them. I think in this situation, one of the things that helps me the most is try to step back and think about what would most doctors do in my situation. So putting away the fact that the child maybe is difficult or maybe the parent is rude, what would most doctors do? What would they check for? What would they think about? What tests would they obtain, etc.? After all, none of us want to be responsible for any surgical abdomen that went home and was unnoticed, or some other serious cause of abdominal pain or severe infection. So thinking about what would my colleagues do in my situation is often very helpful. This is even easier if you work in a unit with several doctors and not a single coverage unit. My personal experience with the emergency department here we work in Vegas, that very often we bounce things off of each other just to get some sense of what some other doctor would do if he or she was in my situation. How would they handle this patient? How would they handle this situation? And that often kind of open your eyes to other options and give you some ideas of how to take care of your patients. This is very difficult to do if you work in a single coverage unit. I encourage you, if you work with other clinicians, even if they're PAs and you think of them as lesser caregivers than you, it is often very helpful to bounce things off of them and ask what they would do. Just kind of gives you more options and open your mind. Rule number 220, plan with the nurse. This is a rule that I think is very important for the sake of working in a team and having good relationship with your nurses who, let's be honest, you really rely on. So very often, almost always, when I step out of the room after taking my history, doing my physical, and talking to the parent, I find the nurse who's taking care of that patient and make sure she is aware or he is aware exactly what the plan is. I think nurses really appreciate being in the loop. They often very much appreciate if I ask their opinion, and sometimes it's very reasonable to do. Some of the nurses I work with, they've been taking care of children longer than I have, and they have a significant clinical experience. So nurses really appreciate when you ask their opinion, or at the very least, make them aware of what the plan of care for the patient is. Do they need an IV? Do they need to do labs? I think it's very difficult for them to just kind of see what we want by looking at the orders that we place on the computer. One of the best advice I got as a physician is take the 1 or 2 or 3 minutes when you step out of the room to discuss the case with the nurse, make them aware of what you're thinking, ask their opinion, make them aware what orders are coming their way, we need an IV, we need to give fluids, etc. Nurses and colleagues really appreciate being in the loop. I think the same thing goes for the respiratory therapist. If there's a child that I'm not particularly worried about, but I think he or she need a very specific type of treatment, making the respiratory therapist aware more than just placing some orders that they need to initiate really helps them out and creates very good relationship between you and them. It's also best for the patient if everybody's on the loop and everybody knows what we're treating. And that is it for today, guys. Thank you very much for listening. Let's briefly review what we learned. Rule number 218, get objective data. Remember, your physical exam and history are often very clouded. Getting some objective data about strength and neurological status with reflexes is very important. Looking at the child's abdomen while you're palpating the abdomen with some distractions is very important. It's always best to get some objective measures, vital signs being another example. Rule number 219, think about what most doctors would do. This is a simple term called standard of care. Your opinion, your experience, your interaction with the patient, with the parent can often lead you a certain way and lead you in the wrong direction. Oftentimes, it's a good idea to step back and think about what would my colleagues do if this was their patient. Obviously, if you work in a unit where there are several of you, I would highly recommend consulting with your colleagues about your patients. There's no ego in asking questions. There is no shame in it. I think it's best for the patient when we consult each other in order to do what's right for the child. Rule number 220, plan with the nurse. When you come out of the room after you have the plan of care for the patient, take the 2 minutes to run it by the nurse, make he or she aware what orders are coming their way, what you think the child needs. And don't forget, some nurses out there are very experienced and have done this maybe more than you. Asking their opinion can also go a very long way. And again, thank you very much for listening to PEM Rules. I hope you learned from the rules and enjoyed the episode. I hope you continue to listen to the podcast. The following outro is a song I worked very hard on. This is Red Hot Chili Peppers' She's a Lover. Great bass line, great guitar line. Hope you like it. Thank you very much for listening.